Hi, everyone. We've come to the end of an outstanding meeting. So many presentations. We learned so much cutting-edge research in the area of DEI. And my role is to summarize over 8 hours of presentations in 15 minutes. I'll do my best. I can never disappoint Dr. Morris, so we'll do our best. But I'll maybe go through the slides a bit fast because I created them during the meeting, so excuse me if there's some typos and some errors. So, all right. I think this is a great time for us to remind and recollect why DEI research is important in the first place, especially as it relates to ADRD research. So there are multiple reasons why DEI is so important to enhance ADRD research. But here are some of the reasons that I thought about. It is clear that DEI will help us better understand the heterogeneity in ADRD neurobiology, in clinical presentation of these disorders in different races and ethnicities. That is coming out in various presentations, the progression of disease in different races and ethnicities, and also how they would respond to the new disease-modifying treatment or the new prevention strategies that will evolve over time. You know that in the new clinical trials, the composition, the diversity of trials in aducanumab and lecanemab and donanemab was really limited. So we don't quite know how different races will respond. It may be very difficult to how non-Hispanic whites respond to these treatments. It is clearly this research will produce more generalizable and translatable findings that will be applicable to larger populations throughout the United States and also worldwide. So I think this is a critical mission of DEI. It'll also help us understand the complex interplay that takes place between the social determinants of health, the AD protonopathy, which is amyloid and tau, and multiple coexisting pathologies that are seen in patients with Alzheimer's. You all know that from autopsy series, there are very few people on brain examination that have pure Alzheimer's. They are almost always coexisting pathologies. So how these pathologies, the AD protonopathy, and the social determinants of health interact to eventually produce the dementia syndrome. So DEI really is going to help us understand that area of research. It'll clearly help us enroll more participants from underrepresented groups in ADRD studies across the ADRC network and also other research programs across the country. It is well known that the diagnosis and treatment of dementia in underrepresented groups is limited. The diagnosis is delayed, the treatment is not given, and these are very concerning data. Research in DEI will help us really enhance early diagnosis and better treatment of URGs with dementia. And finally, we also know that the barriers to access to healthcare among this population, as we do more research, we understand the reasons why they have problems accessing healthcare, and this research will help us address that problem as well. So multiple advantages why DEI research is critical for our field. So we had multiple presentations. I have a slide each for each presentation. I'll go very quickly, but these were really outstanding presentations. Dr. Babulal focused on language and how to communicate about research and science. He talked about the new language guide that he and other investigators, including Dr. Andrea Gilmore-Bykowski from Wisconsin, created. And he talked about 11 tenets and 7 contents. And I think some of the tenets are critical. He focused that one of the tenets is total inclusion in ADRD research, that we should not conflate health disparities with SDOH, that we should not dehumanize, stigmatize, or stereotype language, and not to use abbreviations when we're talking about communicating science and research. And also, we should use language which is preferred by different groups. He shared some best ways to communicate about race and ethnicity, and of course he proposed that there should be a uniform classification system to collect and report race and ethnicity data. He also stressed the data collection and the reporting should be informed by the characteristics and the preferences of the community that these data relate to or involve. And whenever possible, the relationship of race and ethnicity to systemic structural inequities should be addressed. And he talked about communicating about geographic, social, and economic contextual factors, and identified two major ways to address these factors. Dr. Jason Flatt focused on communications about sex, about gender, gender identity, and sexual orientation. He defined these various terms and also defined how each component in the LGBTQIAAP, and this definition revolves around what the people want us to communicate. Also, he shared that there are nearly 3 million older LGBT adults in the United States, and about 20% of them are people of color. And in fact, many of these are about 200% below the federal poverty level, so they really face a number of issues, including poverty. And people who are older than 50 and belong to the LGBT group, they have multiple problems. The first thing is lifetime exposure to discrimination and trauma, health disparities, barriers to access healthcare, and also many of them stay single, they are alone, and they have minimal caregiver support and suffer from social isolation. So there are multiple adverse consequences for older adults who belong to the LGBT group. And then he talked about the data that UDS4 will collect, and I believe this is the first time that these data on sexual orientation and related topics will be collected by UDS4, which will really enhance research in this area. Dr. Consuela Wilkins really addressed an important area. She talked about the structural and research team-based barriers to recruiting marginalized populations. She shared the NIH-defined US populations and also underscored the fact that the classification of race and ethnicities was primarily oppression. There's no biological basis for these classifications. She shared various barriers to recruitment of URG participants, which were discussed and shared by many other speakers, which include mistrust of medical research, competing demands from their job, from their family, from their children, the cost of participating in research, which is gas price and hotel stays and food and the child care, elder care, and so on and so forth, and also the stigma of receiving a dementia diagnosis. And she talked about the IDEA study. You all know that last year IDEA study published data that the odds of seeing elevated amyloid in Hispanic African American population is lower than non-Hispanic white, and they are going to build upon that finding and launch the new IDEA study, which will involve over 4,000 African Americans and 3,000 general population. The presentation by Dr. Jonathan Jackson shared data. He shared data from the donanemab trial and made a case as to why diversifying population and treatment trials is critical. He also described his Forever study, the goal of which is to develop a basic science of recruitment, engagement, retention in ADRD research. The study has 3 different phases that he described very well. And he also underscored the significance of sharing return on value. And for Black population, they relate to genetics, lifestyle factors, ancestry, and remuneration. He also discussed why diversity is difficult. Once again, common reasons, and that is lack of awareness of research opportunity, deep mistrust in the healthcare system, limited transportation, and also limited diversity of the study staff. And his final conclusion was diversity is a stopgap for inclusion on the way to representation. He stressed that JEDI needs more quantification, which is justice, equity, diversity, and inclusion. And then he also highlighted that equity will soon become the primary driver for innovation in dementia research. And once again, underscoring the significance of DEI research. Dr. Coker shared the Adversity Diversity Task Force, how it is working, and some of the lessons learned from the ADNI Diversity Task Force. And these are that the leaders should come from local communities, that the advisory boards are extremely useful and productive, that the recruitment effort should be culturally sensitive and locally branded, and that digital marketing using the social media outlets can be a very useful tool for recruitment, and also the local site participation is critical in diversifying our research cohorts. Dr. Gluck made a very exciting and an entertaining presentation. He talked about the Rutgers Pathway Study, the goal of which is to recruit over 500 African Americans 60 years and older, and he shared that they have 17 years of experience in working with various communities, and they have an community engagement board. They visited 40 churches, 7 mosques, and 13 low-income household 13 low-income household sites. And he talked about how to increase enrollment of Black men into research. The healthy brain study includes saliva collection, plasma ED biomarkers, MRI brain, sleep EEG studies, and they also use participants who serve as ambassadors for their program. Dr. Hudson shared the ARCHES study here at WashU. The aim is to recruit Black Americans with a goal to create a cohort of middle-aged to older adults who are older than 45. They'll have cognitive testing. They'll represent the full SES range in St. Louis areas. They'll have blood draw and MRI, cognitive testing, some questionnaires. There's a community advisory board, and there is a community-based systems modeling which will examine the barriers and facilitators for dementia research. There are certain challenges that this study faced, which apply to many other studies, and that relate to personnel, institutional support, budgets, to have the right community partners, and also have a research cohort which is representative of the local community. Just 2 or 3 more slides. The summary of the session on social determinants of health. We got the definition of social determinants of health. Dr. Zulstorff provided that definition, and that is conditions in which people are born, grow, learn, work, live, and age. And there are different ways to evaluate the impact of social determinants of health on ADRD pathobiology, and measuring SDOH data in ADRD will permit better understanding of the neurobiology of the disease in diverse populations, and also explain the healthcare disparities. There are various determinants, and they're on the slide here, social determinants that are being measured in studies. It is important that the social determinant data collection relate to the local communities. It should be longitudinal, and there is a proposed multi-domain measures of social determinants of health, and they're on the slide here. UDS4 will start collecting these data. At the moment, it's a one-time point data, but longitudinal data likely will be preferred. The data may not be comprehensive, but that's a great start, and I'm sure that more data will be added as time goes on. And also the protocols for data collection should represent the communities which the various centers serve. So a great insight into how social determinants of health will contribute to understanding the neurobiology of ADRD in diverse populations. The community engagement research is critical, and Ms. Gina Green-Harris defined the community engaged research, which is characterized by collaboration, partnership, cooperation, negotiation, commitment to addressing local health needs. What is important is to focus on the guiding principles of community engaged research. This is a long-term commitment in community. You just don't go recruit people and then disappear. In fact, the commitment has to continue whether you have active studies ongoing or not. She emphasized that the community and the research partners are equal, and that is a bidirectional relationship. that the CER builds on the strengths and the resources of the community. It emphasizes local relevance, and that the community should determine their priorities and the various actions to take. It also will help the community utilize various available resources, and she highlighted that as investigators, we should be prepared to apologize if we make mistakes, and also be prepared to change our strategies over time as we learn new lessons. And the benefit of CER are numerous. Once again, it'll help us better understand the ADRD disparities. It'll reduce the mistrust in medical research, build relationships, and also provide a voice to the community to enhance health equity as it relates to ADRD. So in conclusion, I think I used probably all the 15 minutes here. It is important, and I'll have some more ideas tomorrow. We have more time to discuss the returns of this conference. But in conclusion, the focus on DEI across the full spectrum of dementia research is essential. It'll help us better understand the neurobiology of disease in diverse population. And diversifying our research cohorts across the ADRC network and other programs will be key to understanding the differential expression of pathobiology of this disease, the phenotype, the biomarkers, and the potential response to the emerging new treatment and prevention strategies. CER will be pivotal to ensure that the diversity of research cohorts, it'll ensure that our research cohorts are diversified across the country. And there's really an urgent need to address multiple barriers to recruit underrepresented group participants at the micro, meso, and the macro levels. And as a team, we all can do it. We have made huge progress in this area of research. The ADRC network is highly active. There are multiple NIA mechanisms of funding to enhance research in this area. And I have no doubt that over time, we'll have cutting-edge information coming out of DEI research as it relates to ADRD. So I'm going to end here, and we'll have some more discussion tomorrow. Thank you.